Good afternoon, everyone. COE STM Kolkata welcomes all the participants for today's RDLS session. Today's topic is aging with HIV, and the speaker is Dr. Nivedita Dutta. Dr. Nivedita Dutta, ma'am, is working as a senior medical officer with the Center of Excellence in HIV Care at School of Tropical Medicine, that is STM Kolkata. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Sweta, for that introduction. Today, my topic is like slightly huge. It's aging with HIV. Now, there is a vast majority of things I have to cover today, and now I will proceed with it. Basically, one second. Yeah, thank you. We will be discussing about the changing trends in the age of the HIV population, the considerations before treating HIV in aging, managing the age-related non-HIV comorbidities. There are mainly 7 of them. So my discussion will be about the trend of the population, the cohort of people that we are treating now, those people who are coming to our ART centers. If we have observed closely, the cohort is gradually changing. Initially, HIV was a disease with a lot of panic and a lot of mortality, high mortality. And but now with the advent and the introduction of very good HIV ARV drugs, the cohort of people who are coming to our ART centers has gradually shifted from a short survival to a longer survival patients. And now, because they are surviving longer, our patients are exposed to the chronic diseases as the general population. Now, aging of HIV epidemic in India. This is a public health report which was reported in 2020. It shows here that from 2005 to 2010, 15, 20, and 25 onwards, the cohort of people, like the population groups, that it shows a gradual demographic change. That is, initially the people who were HIV positive, they were more younger. The proportion of people were much younger. They were young adults. But now what we find is that most of the patients are in the age group of 40 to 49, or they are above 50. That is, they are the young adults, as we say, elderly adults, as we say. Now, if we can observe the graph, the deep blue and the mustard colors, they both show that the proportion of people in the age group of 40 and above, especially 50 and above, show a remarkably higher percentage. Now, the comparison of overall and comorbidity-free life expectancy between the insured adults with and without HIV infection. Here, this graph, this is also a famous publication. It shows the difference of total life expectancy between the HIV infected and the HIV non-infected. It also shows the number of comorbidity-free years. If you follow the topmost 2 lines, that is the topmost 2 line diagrams, it shows that without HIV, a person lives approximately expected time around remaining at age 21 is 60 years. That is, he has an expectancy of living for 80 years. Total is 80 years, expected another 60 years. Now coming to with HIV, that decreases by 10 years. Without HIV, the comorbidity free years, that is a life where we do not have much of a disease, much of a morbidity, it is basically around 25 or 28 years. That is at the age of 21. So approximately the average count comes to 40 years of comorbidity free year for non-HIV people. That drops down to around 10 years. That is, there's a difference of around 15 years or 18 years. So the gist of the graph is, without HIV, the life expectancy is more. Without HIV, the comorbidity free years is also more. Now, coming to the next slide, it's a pie chart. It shows the proportion of people who are there with us now. It's an Unison Medicare Indian publication. That is, the growing old with HIV is 55% of our cohort population on ARV drugs, and the 45% of the people who are young elderlies, that is the age more than 50 years, if they are diagnosed late in the uh, HIV program, there are new infections also. So it shows that a huge, large proportion, majority of our patients are, they are growing old with HIV, they are on ARV treatment, and we have to follow them up for their other non-communicable diseases because HIV is under control. Now, why do we diagnose late, even if the patient is more than 50 years? And why do we have so many new infections, even if their patients are in the group of more than 50 years? There are reasons behind that. New infections are newly single, probably unhappily their spouses have passed away or they have been divorced or separated. Lack of awareness about HIV, the lack of awareness about the prevention methods, low risk perception, lack of understanding about the risks involved, how the transmission is there, and the low condom use. These are the new infections that crop up beyond the age of 50. And now coming to the diagnosis, that is late onset diagnosis, that is low voluntary testing, failure of us physicians to suspect HIV in elderly. Often we have a patient in the ward who are 65, 70 years, and even if we find a number of OIs in them, the occurrence of HIV does not strike us because we keep thinking, we keep judging that maybe at this point of age he or she will not be HIV positive. But we have to screen for risky behavior, whatever the age and whatever the late presentation. Now coming to the considerations before treating HIV in aging, we have to think about what to be basically the pattern, why HIV is in aging population is important. This graph tells us very clearly why this is important. From 84 to 95, those 11 years, there's a shift from that graph, like the cause of death. It was a study done in the Swiss HIV cohort people. Now the cause of death has a great shift from, like, people used to die because of AIDS, because of non-AIDS malignancy, a little proportion, and infections. But now, with the changing trend of ARV medications, with the vast availability of ARV drugs, with the national programs which have immensely helped bringing all the HIV people under one umbrella, now we find that there is a trend of uh, there's a changing trend. The causes of death in the our PLHIV that has shifted from an infectious and malignancy dependent death causes to a non-infectious, non-communicable pattern of death. Like our patients, luckily we should say that they die of liver disease, they die of non-AIDS infections, they die of kidney disease, heart diseases more, like the general population. And that is an achievement on the part of our ARV program. Now, our cohort of people resemble a normal population, a general normal population. So this is the changing pattern of the cause of death. Now, the top 10 causes of death, this tells us that if you see the percentage change in from 2005 to 2015 in the right hand column, there is a increase in the percentage of the death, causes of death with heart attacks, lung diseases, COPD, the CVAs or the brain hemorrhage strokes, due to diabetes, chronic kidney disease. These are the upcoming causes. Comparatively, in the back foot is the bronchitis, pneumonia, diarrheal diseases, tuberculosis. These are the basically infectious causes. As we see, these are in the negative count percentages. So they show a significant drop. Whereas the non-communicable diseases like heart attack, heart failure, acute coronary diseases, all the lung diseases, pneumonias, these have taken uh, o- a lead because now our patients, they represent a normal general population. So the causes of death also represent the death in normal general population. Now, coming to the non-HIV comorbidities, again, here there's a comparison between the HIV negative and the HIV positive people. And if we observe that the blue box resembles zero number of morbidity, one is the mustard one, two is the green one, and three plus or more comorbidities are represented by the yellow bar. Now, what are the comorbidities usually we see? These are non-HIV comorbidities. These are the hypertension, anginas, myocardial infarctions, peripheral vascular diseases, liver diseases, chronic renal failure, and the carcinomas. So these, if we see the compare the five bar diagrams on the left hand side, that is the negative people with the positive people, we will find that the non-HIV comorbidities have gone up. So what it represents is basically with the advent of time, we see that this is with the adults especially, they have three or more comorbidities in the HIV positive people, but the number of comorbidities is still higher than the general population. Now the polypharmacy, again here the small boxes, the color boxes show that the blue is the no medication, mustard is the one medication, 2, 3 and 4 are the green, yellow and the gray colors. Now, so basically from less than 50, the next histogram is the 50 to 64 years and the next is the 65 years and above. So 5.2% of patients aged 50 to 64 years and 14.2% of patients more than 65 of year received more than 4 medications other than ART. So this shows the number of drugs we are on. Like basically the blue part is reducing as we go ahead with our ages. As we age, we are dependent on more and more drugs for our well-being. Now, for the patient, how is this polypharmacy? How does it affect the patient? How does the multiple comorbidities affect the patient? It increases the expenses with the decreasing income. It increases the pill burden, increases the visit to the doctors and the labs, and restricts the mobility and increasing dependence. So what happens is a person is growing old, the income opportunities for income, the ability to do hard work goes down. On the other hand, the visits to the doctor, the dispensary visits and the dispensary bills, they go up. And on top of everything, there is a restricted mobility. They need support to walk around. They are dependent on others in the family to collect medicines, to go to the doctors. So overall, the non-HIV comorbidities are also quite disturbing for the aged patients. Now, basically, this graph is a very useful graph. What it wants to say in a gist or summary is the treatment of HIV, it reduces the chances of all the comorbidities, the risk of the comorbidities, but it does not nullify them. So in the first year of HIV treatment, as we see in the deep blue the horizontal lines, horizontal bars, in the first year, the comorbidities are higher. In the second year, after the treatment completion of the first year of treatment with ARVs, the lighter blue bar horizontal bars are lesser. That is, they show basically that a patient is at a lesser risk of having the comorbidities. But we have to remember there's a red line in between, a vertical red line at 1. Standardized mortality ratio is 1. So basically what happens is it does not normalize the comorbidities. With the with the introduction of ARVs, a person is less uh, has lesser chances or lesser ratio or lesser chances of having a comorbidity. But introduction of ARV does not mean that the patient will be free of CVD, free of liver disease, or free of the cancers or infections. Now, risks with the aging in HIV, there are basically four groups of things that we have to think about. The aging involves genetics, gender of a person, hypogonadism, menopause. There is risk factors like smoking, dyslipidemia, hypertension, diabetes, obesity, dietary factors, physical inactivity, poor engagement in care, and poverty. So, when a pale HIV or basically any person is aging, these are the issues that are relating his well being to his age. So, a person may be individually, his family may be having a genetic problem with aging, he may be having a genetic disorder or type 2 diabetes, which is really debilitating for the patient. uh, Hypertension, dyslipidemias, these may be things which are they are the traditional risk factors. Now, poverty is another issue. As I said, as we age, our capacity to lowers down, and as the capacity to earn lowers down, that also poses a risk because these the financial things are linked with many other issues. Now, diabetes mellitus, cardiovascular disease, non-AIDS malignancy, renal disease, and osteoporosis. These are major issues that affect our aging with comorbidity. Now, the viruses itself, they pose some risks. Like when there is a even if a person is having a target not detectable viral load, then also the residual viruses, they pose a sort of inflammation in the patient's body, and which results in aging risks. And the treatment with ART and toxicity ART is also not always free of toxicity, and there are drug-drug interactions which also pose a risk with the aging and HIV. Now, coming to the age-related non-HIV comorbidities, we also call them as non-communicable diseases. They are basically diabetes mellitus, the cardiovascular diseases, osteoporosis, renal disease or hypertension, non-AIDS malignancies, mental health, and frailty. I will be discussing them one by one in short. Now, glucose and insulin metabolism. Relative risk of diabetes mellitus in an HIV individual, it increases by 1.2 to 2% compared to the normal people. There's an impaired glucose tolerance also. It is 18 to 35%, and the risk of diabetes is around 9% more in HIV people. Now, HbA1c estimation is done by us on a routine basis, but HbA1c also has its drawbacks in HIV people. What drawbacks does it have? Usually, our drugs like zidovudin and few other drugs, they often cause anemia. And HbA1c, as we all know, that it's a measure of the glycosylated hemoglobin. So, if our hemoglobin levels are low, the glycosylated hemoglobin level calculation is also erroneous. And also, it has been seen that high MCV, low CD4 count, these all affect the HbA1c. So, HbA1c may be falsely low. A patient may be having HbA1c of only 6.5 or 6, but on repeated investigations of his fasting sugar, PP sugar, and the glucose tolerance test might reveal that he is diabetic. So the gist of the story is we should not be relying on HbA1c alone, and it is always good to go for a normal fasting blood sugar and a PP sugar. Now, the diabetes screening and management, fasting glucose has to be done. 100 to 125 shows a glucose intolerance, but that has to be checked by a oral glucose tolerance test. It's always best when we suspect a insulin resistance case, that is the fasting sugar is neither very high, but it's a borderline case. We should always go for a glucose tolerance test. What we do in that, we ask our patients to have 75 grams of glucose from a Glucon-D packet. Then we have to measure it exactly 75 grams. And after taking this glucose, he has to measure his blood sugar after exactly 2 hours. And that is our OGTT, that is the oral glucose tolerance test. And we have a query with our HbA1c threshold, as I said. So fasting sugar should be checked every 6 to 12 months. Consider testing 1 to 3 months after starting or modifying ARTs. As we know, some of our ARTs really have some effects on the hyperglycemia of our patients. The major culprits are the lopinavir-ritonavir combinations and few NRTIs. Now, basically, the NRTIs are lesser, but basically it's LPVR. Okay, NRTI is like we had didanosine, zidovudine is almost obsolete now, lamivudine. They are suspected to cause some amount of hyperglycemia. How to manage individualization is the key to treating diabetes, as we all know. Goal for prevention of complication, HbA1c should be always less than 7, preferably less than 7. Now, coming to the group of ARV drugs we have, and we all know that by now that dolutegravir has a drug interaction with metformin. So whenever we are giving dolutegravir, we are prescribing dolutegravir and the patient is on oral hypoglycemic agents, we have to ask how many tablets of metformin do you take, and it should never exceed a 1 gram dose per day. So the question arises, why do we restrict the metformin dose to 1 gram only per day? The basically 78 to 80% of metformin is excreted unchanged by the renal tubules by active renal secretion. Dolutegravir inhibits the organic cationic transporter. This organic cationic transporter 2, or OCT2 as we call it helps in the secretion of the metformin at the renal tubules. That is, it helps in the excretion of the metformin excess drug. But dolutegravir inhibits the action of OCT2, and thereby the blood levels of metformin remain sustained and high. And this may lead to hypoglycemia and a toxic level of metformin. To avoid that, we have to keep the metformin dose 1 gram or below and not exceeding 1 gram. The other offenders of offenders with sulfonylurea, like glibenclamide, glyclazide, glimepiride, and glipizide, we often prescribe these drugs, but we have to remember that the PIs, basically because they have the boosted dose of ritonavir, the PIs are always the blood level fluctuates. So the lopinavir-ritonavir, it often causes a low dose of the sulfonylureas, whereas darunavir or lopinavir, they always lead to higher low doses in sulfonylureas, when we have to ask our patients for the exact medication he is taking, and the dose needs to be adjusted. Sorry. Now, coming to the basically uh, the DPP inhibitors, we use them. Sitagliptin and linagliptin are being used, but it does not hamper much of it of our basic first line or second line drugs. And we do not use saxagliptin, so we don't need to worry about that. Pio and rosiglitazone, they are quite safe, and they the blood level fluctuates a bit with the PIs. But basically, the essence of the discussion is we have to ask our patients, if you are diabetic, what drugs you are taking and the drug interaction. We can keep this as a handy charter, and the drug interactions need to be looked into. Now, coming to the cardiovascular diseases, my next topic of discussion is the cardiovascular risk burden in aging HIV people. The increased longevity, increased prevalence of CVD. This is a common disease. Finding in all our general population, the cardiovascular risk disease risk increases with aging. That is also common in the general population, not only with the HIV population. And as of now, because our HIV people are living more, luckily we have them for long years with us, so the risk of CVD also increases in them. But PLHIV also has a 1.5 to 2-fold increased risk of the coronary artery disease, and the risk of sudden cardiac death, that is almost 4.5-fold. That's a high count. Now, the relationship between CVD risk in HIV and HIV treatment is U-shaped. What is meant by that? Basically, when we are starting our HIV drugs, there is a rapid decrease of the risk of CVD. But after some years of treatment, the risk again slowly, gradually increases. This moderate increase over time is basically due to the traditional risk factors. Like, it's not because of HIV only, it's because of dyslipidemia, it's because of diabetes, it's because of other infections and other comorbidities, lifestyles, and everything. Huh? And there's a persistent inflammation, as I said. HIV per se, even if we have a suppressed viral load count, you have a virus in yourself which is leading to chronic inflammation. And this chronic inflammation may lead to some kind of coronary artery damage. Now, this is a very common term we discuss nowadays, that is metabolic syndrome. Metabolic syndrome is, there are five factors, and we can, metabolic syndrome is said to be positive, or it is risky, because when it has three of these five factors positive. So what are the five factors we will be discussing about? That is visceral obesity, insulin resistance, hypertension, low HDL cholesterol, high triglyceride. All these five are the five fingers of metabolic syndrome. Now, visceral obesity, that is the weight circumference. As we know, even if we have a very lean patient in Indian population, they may be having a as considerable waist enlargement. That is basically, as we all know, that we Indians have the Southeast Asian people, we have the thrifty gene in us. The thrifty gene always tries to conserve our energy. Because once upon a time, we were those nomadic people who used to hunt for our food, and now we do not hunt. But our body, our gene always keeps us to store, because we know hunting did not give us a continued supply of food. So there was a thrifty gene which was inactivated in our ancestors. But as of now, we regularly have 4 times a day meal or 3 times a day meal. But our thrifty gene is still there. So whenever we have an excess amount of calories, our thrifty gene tells us, okay, store some of it. You might be needing it sometime. So that is what we call thrifty gene. And the effect of thrifty gene is the waist circumference increase in in a otherwise normal lean and thin subject. That is not only with HIV people, that is applicable for our whole subcontinent people. So now, coming to the waist circumference, how do we measure, which is the measurement which is permissible, that is 90 centimeter in female men and 80 centimeter in women, that is coming to 31 and 35 in inches. Now, coming to insulin resistance, fasting glucose if it is more than 100, or being treated for hyperglycemia, diabetes if more than fasting 126, or PPVS more than 200. Hypertension, systolic more than 140, diastolic more than 90, low HDL lesser than 40 in males, lesser than 50 in females, high TGs or triglyceride is more than 150, or the patient is being treated for hypertriglyceridemia. So if we have at least three of these, like the waist is more than 90, more than 80, there is a fasting glucose more than 126, any three of these five factors, if we have, these people are having a higher risk for having a acute coronary syndrome or cardiac disease. Now, the steps in managing the cardiovascular risks. First is identify the risks. If you are identifying the risks, only then you will be treating them. As we see that there is always a request from all our seniors, all the veteran physicians, that please measure the blood pressure of your patients, at least if not at every visit, at least once in 3 months. So hypertension, diabetes mellitus, dyslipidemia, obesity. Here BMI should be 25 in the Indian population, as 25 and above is obesity. Physical inactivity, tobacco use, excessive alcohol, unhealthy diet and nutrition, and family history of cardiovascular disease. These are the risk factors. So if we have a risk factor, we have to address that factor, we have to treat it. And we have to counsel our patients for stopping tobacco, for stopping alcohol, for physical activities, and healthy diet. Now, the step two is managing the risk factors. As I said, ask your patient when he comes for registration. That is the best time to ask for our patient, because at that point of time the patient is also a good listener, and he or she tries to understand whatever is being told, because at the subsequent visits they are always in a rush to pick up their pills. So you ask for any heart disease, any past history of stroke, diabetes, or hypertension. Ask for the symptoms of heart disease: breathlessness, exertional dyspnea, numbness or weakness of the limbs, occasional thirst, polyuria, puffiness of the faces, swelling of the feet, passing blood in urine, loss of weight, any past present treatment for heart disease, any significant hospital admission, current or past use of tobacco, alcohol, sedentary or the type of active lifestyle, premature heart disease, family history of heart disease, all these need to be asked. Now assess the BMI, measure the waist circumference, measure his BP, symptoms of diabetes, signs of pitting edema, heart murmur, basal crepes, lipid profile if available. Now, the step three is, once you have gone into the history, we have seen the factors which may be attributing to the heart disease. Now, we have to manage the risk factors. The ART that should be prescribed preferably in that patient should be a lipid safe ART. If the person has a high risk for heart disease, lipid lowering therapy should be given, management of metabolic syndrome has to be done, and diabetes has to be treated. Consider avoiding abacavir in patients at elevated risk for cardiovascular disease. Here, there were few studies which have highlighted that abacavir may be related to coronary plaques. And that is the reason that abacavir has been related to sudden cardiac events. Now, the management is lifestyle modifications that does not apply to only HIV people, that applies to all of us. Like our lifestyle can keep our hearts good, healthy, and smart. So we have to exercise, preferably half an hour a day, but at least 150 minutes a week. We have to measure our blood pressure. Don't smoke. Smoking cigarettes greatly increases your risk for cardiac diseases because it causes vasospasm. Eat healthy. Eat foods high in fiber. Avoid lesser of fast foods. Avoid lesser of maida and other refined flours. And trans fat should be avoided. Having those fried foods in the same oil, that is the burnt oil. In the fast food joints, we see that one burnt oil is being used for more than 2 to 3 weeks. These are the basic sources of the trans fats. Salt consumption has to be restricted, and food with iron rich in cholesterol. Now, these are the basic interventions. Like if a patient is on placebo, if a patient is on metformin and lifestyle modification, what are the metabolic syndrome, like reductions in the metabolic syndrome? So if we follow a patient from 0 to 4 years or 5 years, as the x-axis is showing, we see that if a patient is on placebo, that no interventions has been done, so the metabolic syndrome keeps accumulating or keeps increasing the risks and the chances of having a acute coronary syndrome. With metformin and with the type of good control of the blood sugar, it decreases. With the lifestyle management, it shows a significant decrease of incidence of the metabolic syndrome. So the intervention is basically has to be done by good control of blood pressure, good control of blood sugar, and lifestyle modification. So the management, we also have to prescribe the lipid safe antiretroviral treatment. That is the we see here with this graph that the tenofovir, TAF, and these groups of NRTIs and the integrase inhibitors, they have lesser dyslipidemias, but the PIs are the notorious ones, as we all know by now, that the ATVR, LPVR, darunavir, ritonavir, they really cause significant good amount of dyslipidemia, and the we have to think about options if this cannot be managed by simple treatment. Now, managing hyperlipidemia, first we have to think about the low risk, moderate, high risk, and the very risky people. We have to do the risk assessment by the atherosclerotic CVD risks factors. I will be showing you the calculator. So we have to assess the risk, and then we have to treat these people. But the summary of this elaborate chart is basically, if the risk is high, 70 or more of LDL has to be treated. If the risk is low, comparatively low, more than 100 LDL has to be treated. The take home from this slide is 70 LDL in a patient who has many risks has to be treated with lipid lowering agents. And if the LDL is 100, just 100, then we have to treat. So, uh, coming to the next slide, I'll explain it again. So the anti-lipid therapy is usually what we give is our atorvastatin or the lovastatin, or the basically rosuvastatin is given. Pitava is new into our continent, but it is lesser used, but it's quite a good drug. Usually we give atorva in a dose of 10 to 40, ranging from 10 to 40. Our PI exposed patients, they need a lower dose of atorva, because the PIs, by inhibiting the metabolism of atorva, maintains a good blood level even at a low dose. Comparatively, DTG, as the bar shows, is very safe with the statins and also our NRTI group of drugs. So the only worry is with our PIs, as we have seen, Rosuva, Atorva, these two big group of drugs need to be given at a lower dose in our PI exposed people. We do not need to go for a 20 or 30 milligram or 40 milligram, because a 10 milligram dose may be equally effective. As efavirenz and nevirapine are not in use, I'm not discussing that part. Now, management, lipid lowering therapy has to be given. Statins reduce the chance of CVD by 44%, so they are a must. They have to be given in our patients who are having dyslipidemias. Fibrates need to be given when the triglyceride, like the fenofibrate, as we say, 160 milligram we usually give, they have to be added to the atorvas. Like, I will not give only fenofibrate. I will be adding, I will be giving my atorva for 3 or 6 months. I will see the improvement or the changes in the lipid profile. If it does not work for my TG profile, then I will be adding the fibrates. So, and also the TG level when it's quite high, more than 400. Omega-3 fatty acids, niacin, and acetamide, these help our fatty acid, these fatty acids, they help to keep our good cholesterol high, and they help in our normalization of the lipid profile. So the atorva is usually in a dose of 40 to 80, and rosuva is in a dose of 10 to 20. But we have to remember that usually with our patients, we give a atorva dose of only 10 to 20 and not beyond that. And Simva and Lova are not basically used, but they are contraindicated with the PIs that we have to keep in our minds. Now, this is the American College of Cardiology atherosclerotic cardiovascular disease risk estimator. This is a calculator. This is used for patients within the age group of 40 and 75 years of age. This basically gives a 10-year risk of cardiovascular events. Here, what we measure is age, sex, race, systolic blood pressure, diastolic blood pressure, the total lipid profile is needed, history of diabetes, hypertension, smoking, use of statins, and the aspirin therapy. All these are calculated. It's just a basic calculator, and it tells us at how much risk is a person, at how much risk am I to have a cardiovascular event if I have all these issues. Now, less than 5% is considered low risk, 5 to 7.5% is borderline, 7.5 to 20 is intermediate, and more than 20% is a high risk person. No, here we see that it's showing 17.7% with smoking cessation, So statin therapy, BP medication, aspirin therapy. So 17.7 is intermediate risk. So this calculator helps us, it helps us to give an impression that are we really at that risk, and do we really need to modify our lifestyles. Now, my next topic is osteoporosis. So, coming to the derangements in the bone metabolism, we know that there are few factors, like as I said before, patient-centric factors, virus-centric factors, treatment. All these affect our bone mineral density. So, a bone mineral density may be due to individualistic gender, menopause of a female, hypogonadism, higher risks with smoking, alcohol, physical inactivity, malnutrition, vitamin D deficiency, hypothyroidism. These are factors which cause bone mineral density, decrease in bone mineral density, even in non-HIV patients. Okay. Now, coming to the virus factors, as I have said previously, there's an inflammation and immune activation in the body of a PLHIV. There's a low CD4 count and high viral loads and co-infections with other viruses. These all lead to an inflammation process running inside the body. Now, there are the treatment factors, that the side effects of the ARVs and the treatment with the steroids. These also lead to osteopenia, osteoporosis, and fractures. So, what is osteopenia? It's a lowering of the calcium blood levels. That is the beginning of the low mineral density. Osteoporosis is a frank low density, and that leads to the fracture and avascular necrosis. Now, PLHIV, a 6.4-fold increased risk of having low BMD, and they have 3.7-fold increased risk of osteoporosis. There are two graphs on two sides. Left one side shows the women and the right hand side shows the men. There's a comparison between the HIV positive and the non-HIV people. The mustard line is the HIV people, and the gray line is the non-HIV people. As we see, the graph shows us that the fracture prevalence increases as we grow older, both in men and women. The fracture prevalence increases in both HIV people and non-HIV people, but the risk is much higher in the HIV positive people. This is a huge study. It was done with a lot of patients together. So the comparison arm was also very good and robust. So what we have to think about is ART naive people, 67% osteopenia is overall 67%, 70.4 is osteopenia, 29.6 is osteoporosis. ART experienced people 80.4, total osteopenia is 63, osteoporosis is 36.6. Now, we will be discussing about how to evaluate a patient, whether he is having a fracture risk, whether he is having an osteopenia or osteoporosis. But the best ever method is to go for a bone mineral density, that is a BMD scan. It's not a very expensive test. Usually it is available in all our medical colleges. We have to just refer my patient. So if my patient is an elderly, it's an adult patient, more than 40 years, best is to do the FRAC score. It's another score which is available with all, it is available as a calculator, available online everywhere. So we have to assess the risk by FRAC score, low risk, moderate, and the high. Okay. So if it is a low risk, we reassess every 3 years. If it's a moderate risk, we have to go for a DEXA scan. And if it's a high risk, then we have to go for our treatment also. So DEXA monitoring, if we have ever seen a DEXA scan report, basically the normal scoring of the T score, there are two types of score. There are T score, there's also a Z score. The T score compares the my BMD with a normal young adult, and the Z score compares my BMD results with a age, sex matched adult. Okay, same to same age, same to same sex and race. Okay, so the T score, the acceptable T score is from -1 to +1, and beyond -1, it's basically osteopenia, and beyond -2 to 2.4, it's basically osteoporosis. Now, this is a FRAC score. As I said, it's a measure of how risk prone am I to have a fracture. So we have to put our country, that is our basically our race, and then there are age, sex, weight, height. These have to be entered. And what is considered is basically smoking, the exposure to glucocorticoids or the any steroids, history of rheumatoid arthritis, then the fractured hip, parent fractured hip, previous history of any fractures, history of alcohol, osteoporosis, and BMD. The FRAC score is dependent on BMD. Without BMD, we cannot calculate the FRAC score. It's a basically high risk is 10% or more, and wait. The high risk is 10% or more. More than 20% risk is basically it's a risk for major fractures, and for hip fracture, more than 3% risk is also considered indication for pharmacologic treatment. But the basic take-home message is, if I find my patient complaining about hip pain, low back pain, pain while sitting in a chair, pain while getting up from a chair. He is telling me of aches and pains all over his body. We really need to think about the bone mineral density test, a BMD scan. It's not very expensive. A BMD can help us to identify the osteopenias and the osteoporosis. Majority of the Indian females are in the range of osteopenia. That is the BMD is beyond -1. It's in a negative scale. So supplements can be given. These are treatable things which can be easily repaired. So why should we force or push our patients towards fractures and non-mobility where these things were preventable? So lifestyle modification, exercise, smoking cessation, alcohol reduction is important to increase our bone mineral density. As we know, as more we exercise, our hormones are released, and the bones become stronger because the mineralization continues. Smoking really damages because of the increased osteoclastic activities. And now the pharmacologic therapies supplying vitamin D and calcium, dispensing heart, that is the HIV drugs that are safer for the bones, replacing tenofovir for a safer tenofovir alafenamide or abacavir, replacing the PIs with DTG. As we have mostly heard that the PIs are notorious, and we already have 4 or 5 case studies where the PIs are responsible for avascular necrosis of the hip joints. And these patients unhappily are really chair or bed bound nowadays because of the hip necrosis. The acetabulum or the hip joint has been damaged, and that has been eroded to such an extent that the patient is now chair bound. So whenever a patient at our ART clinic is complaining of hip pain, low back pain, leg pain, or back pain, please do not ignore if the patient is on the PI group of drugs, because this may be a case of avascular necrosis of the hip joint, and the PIs need to be taken off as soon as possible. Now, bisphosphonates, as we all know, that they are the good group of drugs for the long-term management of the calcium levels in our body. Alendronate and the zoledronic acid. Alendronate and the ibandronate, these are the oral medications which have to be taken. Alendronate weekly and ibandronate is monthly. And zoledronic acid, it's also very useful, or denosumab, because denosumab is now much more in use, and these are yearly medications. And there's a zoledronic is also useful because it's an yearly injection. Now we can always prescribe these drugs, and they are really useful for our patients. But we also have to think about the safer HIV drugs. Now, coming to the studies which have shown that this is the lumbar spine BMD and this is a hip BMD on the right hand side. Now, this is the mustard line is ARV combination with TAF, and the bluish gray line is the ARV combination with tenofovir disoproxil fumarate, that is TDF. The upper line is with TAF and lower line is with TDF. So the comparison is like these show that the BMD study is worse with tenofovir DDF, and it's much better. That is, it is within -1, and as I said, it's acceptable. -1 T score is acceptable. So uh, the outcome with tenofovir is quite poor. And as we all know that tenofovir causes bone demineralization, it causes the proximal renal tubule dysfunction, leading to the draining out of calcium. Now, greater improvements in BMD with zoledronic acid versus switch from the TDA. This is a study result where it has been seen that prescribing the bisphosphonates is superior. It has a superior effect than only changing my tenofovir. Now, coming to osteomalacia and osteoporosis, osteomalacia is basically calcium deficiency, sorry, basically vitamin D deficiency along with calcium deficiency. But osteoporosis is basically calcium deficiency. It's a multifactorial that also has other traditional risk factors. So we have to think about osteomalacia is represented by bone pain, tenderness, proximal muscle weakness, waddling gait, whereas osteoporosis is usually silent. Now, coming to osteomalacia, a patient will be always complaining of bone pain, having pain in the hips, in the lower limbs, and the proximal muscle weakness, difficulty feeling aches and pains throughout the day. We have to look for pseudo fractures, like the looser pseudo fractures usually we have in the upper shin bones. Now, the osteopenia is there in both of them, and we find that in osteomalacia, there's a low calcium, low phosphate, but high alkaline phosphatase, high parathormone because of the calcium draining. And in osteoporosis, comparatively, we have a normal, mild to moderate vitamin D deficiency. Now, we have to treat both of them. In osteomalacia, our treatment will focus on more vitamin D and the treatment of the underlying cause if it is a hormonal deficiency. And with osteoporosis, it will be the bisphosphonates in varying responses. Now, dolutegravir and calcium and iron, we all know by now dolutegravir cannot be co-administered with calcium or iron. If we have to give dolutegravir, we need to give it 2 hours before calcium or iron or 6 hours after calcium or iron. Now, my next topic is renal disease or the renal hypertension, as both of them together. Now, renal is basically uh, these are the risk factors for new onset kidney disease. That is a BMI, smoking, hypertension, age, and diabetes. All five need to be considered when we are thinking about HIVAN, or that is the basically HIV drug-induced liver disease, kidney disease, sorry. Basically, it's not only HIV, it's all these factors, they are contributing to the risk of developing CKD. So the odds ratio, that is the which are the things that are relating more, contributing more to kidney diseases, as we see age, diabetes are considerable risk factors, and hypertension, smoking, BMI are also there. Now, the low risk and the high risk, it's okay. EGFR, usually we don't go for this calculation. EGFR less than 50, they need a change of ARV regimen. And now, nephrotoxic drug is tenofovir. Atazanavir is avoided because of the renal stones. Lopinavir tenofovir is for another cause, that is for dyslipidemia. Now, the overview of non-AIDS malignancies. Now, we all know that there is a high chance of cervical cancer in our HIV people. We need to screen for it. The repeat screenings have to be at ART initiation, it has to be done after 3 years, and follow-up also has to be done. The breast cancer screening is important in women aged more than 30 years. At ART initiation, it has to be done, or once in 1 to 3 years thereafter. Now, how we do the breast examination and self-examination has to be taught to our patients. Now, screening for the oral cancers is also important. Once in a while, look into their mouth. If they are tobacco chewers, then they regularly need inspection of their mouths. Ask them for any ulcers, non-healing ulcers, any growth in their mouth or tongue. And the mental health is something that should not be ignored in our PLHIV. And we know that depression and other psychological issues that crop up in our PLHIV is twice as likely as the normal people, because we have our stigmas, rejections by family, financial insecurities, dependence, the fear of disease and death that is there with our PLHIV. Over 50 to 75% of study groups of older adults with HIV show depression. Non-adherence to all medication is an effect of depression, and there are high rates of suicide. So what we have to do is we have to counsel our patient. The fear of disease has to be eliminated in them. Uh, Counsel them like these are things like you cannot avoid it, but at the same time, we have to talk about the good effects of our ARV drugs, the efficacy of our ARV drugs, which keep our HIV people very healthy and suppressed viral load. Positive thinking, if needed, psychological counseling can be given to them. We have counselors in our ART centers, sit with their patients, ask them if they have depression and how to ask them for depression. The basic two questions you need to ask is, do you really feel very down, depressed, or hopeless nowadays for the past 2 weeks? Has it occurred to you that there is no point in living beyond? You don't find any interest in life? And do you not find any pleasures in the activities you used to find previously? Like a person may be addicted to a TV serial. Maybe he liked watching some matches or movies. Uh, has it occurred to you that you do not find pleasure in any of those activities? So that is a very common symptom of depression. And we have our psychiatrist with us. Usually in our medical colleges we have our respective departments. It is always best to refer the patient with a knock to the psychiatrist, because that helps to control the depression, and it's a treatable disease, so why not go for it? So managing depression, so slowing down, relax, keep calm, be positive, take it easy. These are measures to stress management. Keeping ourselves busy is very important. Social networks can always help us. Efavirenz is no longer in use, so that was something which caused CNS effects. But we have dolutegravir with us, and dolutegravir also causes some amount of CNS activity, and dolutegravir may be a cause of depression also, though it is rarer than efavirenz. So we have to keep that in mind. So counseling is basically lending a sympathetic ear, teaching coping mechanisms, and giving medications. If needed, we have to refer them to the respective departments. So coming to the last topic of my discussion is frailty. What is frailty? Basically, weight loss that is unintentional. Fatigue, which is reported by the patient, him or herself. Low physical activity, that is also reported by the patient, or you ask them some leading questions. Weakness, you measure the hand grip of strength of a person, and slow walking speed. So if you have any three of these five vital signs, then the geriatric physician will tell you that a person is frail. So these are signs which should not be ignored. And if a person is having frailty, we have to think about it, we have to treat it, we have to look into the reasons behind it. Now, unintentional weight loss, weakness, exhaustion, slowness, low physical activity, these are signs of frailty which are seen in aged people, but the percentage is much, much more in the HIV infected people. So this graph tells us that the percentage of frailty increases with our HIV people. So we have to search for these, and this is age related also. So our only our search can help us to treat it. So frailty is related to physical, social, emotional, metabolic, cognitive, and sensory factors. Now coming to physical, regular exercises, balance, and the flexibility trainings can be done. As we all know that exercises help us to release endorphins. It keeps us better. Like they are the good psychological hormones, and they keep us happy and hearty. So we have to exercise regularly. Exercises, as I said, also helps in the bone mineralization. It improves our balance. It improves our flexibility. That training can be done. Social factors are self-help groups, social networks. Keep yourself busy within your community. That is important. Emotionally, a person needs to be emotionally happy, emotionally stable to keep himself well. Metabolically, the diseases have to be treated, whether it is a long-term diabetes or a hypertension or any other hormonal disease. Sensory and the cognitive features. Basically, it's a it's a wholesome disease. Basically, frailty is all the interventions have to be taken into consideration, and only then either we use it or lose it. Beyond the drugs, we have to think about easy prescriptions. We have to think about avoiding too many pills, making it easier for him or her to consume all the pills, and advice about a good and healthy nutrition. Involving family, caregiver, or support groups is very important. We have to ask open ended questions. We have to be a good listener. Ask your patients what problem they have. Do they really suffer from any ailment? Are they on co-medications? Is he or she having any difficulty coming to the RT center? Mental health, as I said, in the past 2 weeks, ask your patient, have they enjoyed doing those things which they usually previously enjoyed? Are those pleasures equally pleasurable to them? Avoiding multiple health visits, comprehensive health care, because as we know, every visit is not at all happy for a patient. Standing in long queues, waiting for her or his turn to see the doctor, transport costs, and and the loss of wages, all these hamper our patients' daily life. So we have to avoid the multiple health visits. And as I said, basically, HIV is moving into a age of uh, elderlies. So as we the healthcare people, we are also aging with them. So we need to look beyond what we see. We have to see into the strategies how to help these people live better. Uh, Avoid as much as possible cross referrals, so that do not have to run from one doctor to the other. Advise them on lifestyle changes, give them statins, give them bisphosphonates whenever needed, give them calcium, iron. Try to give them a wholesome treatment at your center level. Vaccinate the elderly as and when possible. Hepatitis vaccine is there, pneumococcal vaccines are there for the elderly, and see that the children are also vaccinated. Optimize the HIV drugs according to the need of the patient, and the topmost priority is listen to them. Now we have some tools. I was talking about HIV drug interactions. This is one website. You also have the HIV Liverpool drug interaction. EGFR, we have calculators. It's very easy. Bone density, fracs, and the ASCVD score. These are also, there are calculators. And for drug resistance, we can always refer to the Stanford website. Now, that's the end of my long discussion. I hope it was understandable. If anybody has any query, you are free to ask.
Thank you so much, ma'am. Any questions from the participants? Please feel free to unmute your mic, or you can just put your questions in the chat box.
I think that was a very lengthy discussion. People
Yeah.
are exhausted. Okay, any discussions, any queries you have, you're always free to write to coestm1@gmail.com. Or Dr. Nivedita, most of you have my number, and they can always freely ask me. Thank you,
Thank you.
Sweta.
Thank you so much, ma'am. Thank you
Okay.
to all the participants for patient listening. We'll conclude this session now. We'll soon share the recorded link and PPT as well. Thank you.
Oh, thank you, Sweta.
Thank you, ma'am.